Good afternoon to all those who have joined this session. A very good afternoon. Greetings from NITRD, E-Niti, nurses' efforts to eliminate TB in India. To strengthen the nursing fraternity of India, to keep updated of TB, E-Niti conducts training and upskills the nurses of the different healthcare system across states. That means moving knowledge without moving people became more critical than ever before. This platform brings together healthcare providers, subject matter experts using video conferencing technology and brief lecture presentation. And of course, case-based learning. Welcome to all those who are still joining. I could see that you all are joining from different states. Thank you for joining. Now, for all those who have joined new today, I am Sheema John, moderator for today's E-Niti Clinic, and I'm from NITRD, our own institute. This is our 19th clinic, and the topic for today is CLABSI, Central Line Associated Bloodstream Infection, a very, very important topic today. We conduct this clinic on every last Friday of every month. So please be ready for last Friday. Write down, mark the date. The major milestone is distribution of certificates after every class to all the participants. But please make it sure that you join separately and not in groups to avail your certificates. Initially, it was for the nurses of our institute, but later, after the official launch, it was made public, with an objective to share and expand the knowledge with the vision to involve other institutions as well. I request, once again, I request to join all of you separately so that you can avail certificate. Now, let me introduce our, I think I'm audible to you all. Can anybody please reply, am I audible?
Yes, yes.
Yes, yes.
Okay, thank you. Now, let me introduce our dynamic team here with us. She's our presenter here today, Miss Sonia. She's going to present the topic on CLABSI, as I've told you earlier. She has already worked for 8 months in our ICU, and she's been here since more than 1 year. And welcome you, Sonia. Be ready with your topic. Now, next is our nursing superintendent, ma'am, Dr. Anita Rani Kansal. As you could see her here. We have some problem with our camera here, but we have our technical team has supported us in this. She has made some little bit changes, but I can assure you that we'll be online off the time. If any glitch appears, please, I'll ask apology earlier. Prior, I'm asking apology. There is some problem with our net here. Now, the special invite. Now, our special invitee, Dr. Anita Rani Kansal. Good morning, ma'am. She's nursing superintendent of our institute. Ma'am has been the master trainer for training of nurses in TB by ICN. Ma'am has been recognized by the ICN TB MDR TB project as a leading light on recognition of her outstanding contribution to the care of people affected by TB. Good afternoon, ma'am. Welcome.
Thank you. Thank you, Shiva.
Now, with us, our expert is Dr. Ritu Singhal. She is offline. Dr. Ritu Singhal. She's joining us. She will be joining us. Just 2 minutes, she will join us. Dr. Ritu Singhal, she's a professor and senior specialist, SAG, Department of Microbiology, and National Reference Laboratory TB, NABL Accredited and Center of Excellence, WHO, at National Institute of Tuberculosis and Respiratory Diseases, our own institute. She's international and national level trainer in TB, DRTB diagnostic technologies for Central TB Division, SARC, and International Union, USAID and FIND. She's been awarded Professor A.N. Chakravarti Memorial Prize for Best Published Paper in Mycobacteriology by IAMM. Awarded Outstanding Achievement in Sequencing work done at Advanced Molecular Diagnostic Laboratories and Integrated Center of Genes and Technology, National Jewish Health, Denver, Colorado. Good afternoon, ma'am, if you're there. I can't see you.
Yes, I'm here.
She's-
I'm here. Thank
Good
you.
afternoon. Good afternoon. She has just joined. Good afternoon, ma'am, and welcome to this session. Thank you for being an expert, ma'am.
Thank you.
Before we start the session, I request all of the learners here, attendees, to mute their microphone so that there would not be any disturbing noises. And you can enable it when you have queries. There may be technical interception or poor low quality but I assure that it could be for a short period of time. Please keep patience. Do not do multitasking and keep focused on the session, please. Thank you. I request our director, ma'am, Dr. Manpreet Bharla, if you could share some opening words with us. Ma'am, are you there? Good afternoon, ma'am. I can see you.
Yeah, good afternoon. Can you hear me?
Yes, ma'am. You're quite audible.
Yeah. So thank you, Shima. And good afternoon, everyone, and welcome to today's session of E-Niti, that is Nurses' Efforts to Eliminate TB in India, TB Clinic for Nurses program. And as Shima has told you, the program, what is the objectives of the program are to disseminate the best practices of nursing care for TB patients, then to improve the care within the institute and expand it to other TB institutions. And we also want to cover various topics like airborne infection control, MDR TB, and new drugs used for the treatment of TB. And I think these efforts are aimed to bring down the mortality and morbidity, and so that we can reduce the mortality and morbidity in TB patients. And lastly, to create awareness, and I think all these efforts will lead to stopping the chain of transmission of TB. So the topic for today's clinic is central line associated bloodstream infection, that is CLABSI, which is a very important topic, and it's an important part of the infection control this thing. So as a chairperson of the infection control committee of this hospital, this topic is very important for all, and I think you should listen to this very carefully. The presenter is Dr. Sonia. She's a nursing officer, and the expert for today's session is Dr. Ritu Singhal. So I thank you, and I wish you all the best for today's session. Thank you.
Thank you, ma'am. Your insights would be greatly appreciated. Thank you, ma'am. Thank you for giving the tone of the session. Now I move on to Miss Sonia to start with the session.
Good afternoon, all the attendees, especially ma'am, director ma'am, for your appreciating words. Now I am going to present case presentation on CLABSI. I am introducing my patient. The history of patient is as Mr. Rahul Kumar, 32 years male, admitted in the hospital on 22nd August 2024 with the complaints of as chest pain, fever, hypotension, loss of appetite since last 10 days. The vital signs of the patients.
Excuse me for interrupting her. Are you all audible? Can you all hear her? Please, someone unmute yourself and say.
Yes, ma'am, you are audible.
Thank you. It's okay now. Start.
The vital signs of the patient at the time of admission as temperature was 104 degree Fahrenheit, the pulse rate 163 beat per minute, the respiratory rate 45 breaths per minute, the BP 88 by 54 mm of HD. The patient put it on BiPAP support 16 by 6 centimeter of H2O with 55 liters per minute oxygen via nasal prong. There is no IV accessibility as the patient is very thin and malnourished. After taking consent, the CVC line inserted for fluid resuscitation at emergent. The investigation results shows on urgent basis the TLC count was 15,000, HB 9.4, SGOT 22, SGPT 41, sodium 122 milliequivalent per liter, potassium 3.3 milliequivalent per liter, pH 7.31, and bicarb was 22. The provisional diagnosis of the patient is as pulmonary tuberculosis with hypotension and hypokalemia. The CVC inserted on 22nd August 2024 at 11:30 p.m., the right subclavian with the USG guided procedure. The initial treatment started by our physician was injection Rentec 50 mg/bd, injection AMSET 4 mg/bd, the injection diclofenac 75 mg/bd, injection cefosalbectam 1.5 mg/bd, 15-liter fluid resuscitation done immediately as the patient has severe hypotension. The tab calcium 500 mg OD, the tab azithromycin 500 OD, the tablet ferrous sulfate OD. The culture report of the patient as urine sterile on 25th August. This report has collected by us. The report shows urine sterile. Blood culture shows Pseudomonas organza from CBC sample. The sample has collected from CBC line. The TLC count on 25th August was 25,000. The treatment started after the culture report. The patient has sensitive from those are started injection meropenem 1 gram TDS, injection amikacin 500 mg OD, injection ciprofloxacin 400 mg BD. Investigations on 29th August 2024 was as TLC count 12,000 HB 10.1, sodium 139 milliequivalent per liter, potassium 4.4 milliequivalent per liter, and pH was 7.35. Now the patient is recovering from the former condition as he is on BiPAP supports 12 by 6 centimeter of H2O with 2-liter oxygen support via nasal prong. Now it is very important to discuss what is CBC. Before we are going to discuss about CLABSI, this is very important to know what is CBC. CBC, a central venous catheter, also known as central line, is long, soft, thin, hollow tube that is placed into the large vein that ends into cavo-arterial junction. What are the indications for CBC? As we know that whenever we are going to perform any procedure, we need some indications as volume resuscitation, emergent venous access, nutritional support, inotropes and high risk medicines, hemodialysis, CVP monitoring, and some others are also there. Types of CBC. There are majorly 3 types of CBC: tunnel, PICC line, subcutaneous port, or chemo port. Insertion site of CBC. We can insert CBC various sites, but majorly and importantly, we choose 3: internal jugular vein, subclavian vein, and femoral vein. The most important site to insert a CBC is subclavian vein. It is very preferable as it decreases the chances of infection to the patient, and least commonly used site is femoral vein. Risk factor associated or for developing CLABSI are as lack of sterility. Whenever we are going to perform any procedure, it is very mandatory or important to maintain the sterility of the area of the patient of the procedure. The site of infection, as I already told you, the least common site is femoral. Whenever we are going to perform CVC insertion, try to put the CVC on subclavian vein or internal jugular vein, as femoral causes the more infection to the patient. Multiple lumen and stopcocks. CVC has 2 types, double lumen and triple lumen. It is decided by our physicians to put double lumen or triple lumen, but it is very important to choose less stopcocks or lumen CVC, because the more the stopcocks, more the hand handling, the more the infection to the patient. Failure to remove unnecessary lines, like if we are using 4 ports, if there is any chances to reduce the number of lines, we can we can reduce. So we should reduce the number of lines. Immunocompromised patient has already has a low immunity, low immunity and low power to fight from the bacteria. Chemo drugs and TPN. TPN is major and very important to cause CLABSI if the patient is on TPN, as TPN has their own important responsibility. While we are administering TPN, there are some important points to keep in our mind. So TPN is also very important to cause CLABSI, prolonged stay of the patient, and any other sources which can cause the CLABSI. Central line associated bloodstream infection. Now we come to the point, what is CLABSI? A CLABSI is a primary bloodstream infection that develops in a patient with a CVC in place within the 48 hours period before onset of bloodstream infection that is not related to infection on other side. Means the patient has come to the hospital after 48 hours of the patient stay or insertion of the CVC line, the patient get infected from the CVC. Because of the CVC, the investigation shows TLC count high, signs of infection. It indicates patient is going to the CVC, CLABSI. Pathogenesis of CLABSI. There are two types of pathogenesis of CLABSI: extraluminal and intraluminal. First, we talk about extraluminal. Pathogens migrates from the external surface into the skin. Means the source is outer. Okay. The entry site often occurs 7 days after insertion. According to the CDC guidelines, it has the significant role that the extraluminal infection mostly occurs after the 7 days. In intraluminal, herbs gets contaminated and organisms enter into the lumen, leads to intraluminal colonization. It is more common. It is our lacking if we are giving patient intraluminal infection. It is our lacking because we are handling the lumens commonly and mostly and frequently. Signs of central line infection. There are many infection signs of central line, but there are some measures from those: fever, soreness around site, pus, patient has chills, redness and blood, bad smell, oozing from site. Criteria for diagnosis of CLABSI. As we know, whenever we are going to diagnose something in patient, like we are going to diagnose TB or any other disease, we have some criteria. Likewise, there is a criteria for CLABSI to diagnose this patient has CLABSI or this patient has no CLABSI. First is organisms cultured from blood is not related to an infection at another. Means the culture has positive from the central line itself. No, there is no another cause of culture positivity. The CVC line was placed for more than 2 calendar days. Means after 48 hours of central line insertion, we can say if there is an infection just because of central line. The CVC line was placed on the day the blood culture was taken or the day before the blood culture was taken. A patient has recognized pathogen cultured from one or more blood culture. The patient has at least one of the signs like fever, chills, hypotension, or clinical evidence of systemic infection. CLABSI bundle. Whenever the patient get CLABSI, we use some bundles. The most important and the significant bundle in HAI hospital acquired infection is CLABSI. CLABSI is majorly used in ICUs or emergencies. So the CLABSI bundle it is a set of evidence-based interventions related to disease process that when executed together in result better outcomes Then we implemented individually. CLABSI bundle. Bundle means a set of interventions. Means we are not using a single thing to approach the to reduce the infection. It is not. It is a bunch of interventions we use to reduce the CLABSI or to prevent the CLABSI. CLABSI bundle has 6 points as per CDC guidelines. First number, hand wash before all procedures. Number 2, use maximal sterile barrier when inserting a central line. Number 3, use 2% chlorhexidine gluconate in 70% alcohol before inserting a central line. Fourth point is avoid inserting a central line at femoral vein. Fifth point, evaluate conditions of central line daily. Sixth point, scrub the hub with 70% alcohol for at least 15 seconds. The most important point from all of these is, as we are nurses, scrub the hub whenever we are going to put whenever we are going to administer any injection fluid or taking sample from the CVC. It is very important to scrub the hub. We scrub the hub in a way 5 times clockwise and 5 times anti-clockwise to disinfect the hub. CLABSI bundle divided into two. CLABSI bundle has two sides. First, insertion and second, maintenance. In insertion bundle, insert only if clinically indicated. If there is need for CVC insertion, then only you should insert the CVC. Catheter with minimal number of ports. If you have need only one port, to use only one port. There is no need for go to the second port, because the more number of ports, the more chances to give the CLABSI to the patient. Hand hygiene, aseptic technique, 2% chlorhexidine solution for at least 30 seconds before putting the central line. In insertion bundle, most important solution we use is chlorhexidine gluconate to reduce the infection entry to the patient. Maintenance bundle. Maintenance bundle is very important for all the healthcare providers, especially nurses, because we handle the patient more than the doctors or physician or surgeons, because we spend more time with the patient at patient side, as we should always follow the maintenance bundle and also standardize our care. Hand hygiene, skin asepsis, avoid femoral abscess, cover CVC with sterile drape, scrub the hub with 2% chlorhexidine or 70% alcohol, assess for any color changes, proper documentation. Why we need the proper documentation? If we are not putting the correct date on CVC line or timing, it will decreases the patient's safety. Like whenever we are going to redress the patient, we need ki before going to address, we have to check there is date or time properly. Flush before and after. Care provider. According to CDC guidelines, there is a CLABSI prevention checklist. The CLABSI prevention checklist as same as we have discussed in maintenance bundle. Common pathogens of CLABSI. There are some important organisms which can found in CLABSI: Candida species, Andrococcus, Coagulase negative Staphylococcus, Staphylococci, Klebsiella, Enterobacter, Pseudomonas, Streptococcus. Flushing technique. It is very important to flush CVC line before and after use. There is a mnemonic SHASH. S stands for saline flush. A stands for administer medication followed by flush. Like when we are going to administer injection monosep, firstly we have to flush the line with saline, then injection monosep, then after the saline flush. H stand for heparin flush. Some patients had decreased PTINR or some other blood investigations deranged. So if there is indicated to flush with heparin saline, then only you can use the heparin flush. Assess for dress. Assess for dress means D for discharge from CVC line, redness around the CVC line, ecchymosis means there is any leaking from the blood vessels, swelling, and signs of infection like fever, chills, increased TLC count. Types of dressing. In central line, we have different types of dressing like transparent and semi-transparent. The transparent and semi-transparent dressings used for 7 days, gauze dressing used for 48 hours, and medicated or chlorhexidine dressing used for 7 days. Dressing solutions. The dressing solutions are 2% chlorhexidine, 70% alcohol, or 0.9% normal saline. Assess for ACL. A stands for assess for confirm the location of the catheter. C stands for clear to avoid any incompatibility, and L to lock the lumen. To lock the lumen is very important. The clamp it showing in the picture in the image is whenever we are administering any medicines. Before administering any medicine, we have to open the clamp, flush the saline. After putting the medication, we have to lock the lumen, because if we not lock the lumen or lock the clamp, the blood escapes from the line and patient has blood loss. Assess for alert. Alert is very important in CLABSI. A stands for apply transparent dressing. L stands for check for patency of line. E close system, as I already told you, to lock the clamp. Re-examine for dressing whenever you see dressing is soiled or there is any blood stain or any other soilness you are seeing. You can re-examine for dressing and redress the CVC line. T stand for date and time. Complications of CVC. There are some complications of CVC like catheter dislodgement, DVT, deep vein thrombosis, air embolism, pain, catheter fracture and migration, superior vena cava syndrome, phlebitis, and infection at site. Prevention of the CLABSI. As we all know, prevention is better than cure. That's why we have to prevent the patient from getting CLABSI. Aseptic technique, hand hygiene, early removal of CVC, healthy handling, flag system. Flag system means if we have two medications, if we are not putting the right label on the medication, it can cause incompatibility and cause harm to the patient. The flag system is very important whenever we are using the CVC ports. Proper labeling should be there. Proper documentation, follow standard guidelines. CLABSI rate calculation. CLABSI rate calculation. The CLABSI rate is calculated per 1,000 central line days by dividing the number of central line days and multiplying the result by 1,000. As according to WHO, CLABSI rate is 3.5 per 1,000 central line days. National Health Safety Network shows 1.2 per 1,000 central line days. International Nosocomial Infection Control Consortium shows INICC 4.1 per 1,000 central line days. In India, it is very high. We need to decrease the of the CLABSI in India, 5.1% per 1,000 central line days. Nurses' responsibility. As I already told you, nurses are the main handler of the CVC line. We spend more time with patient at patient side. So there is some important points we should always keep in our mind whenever we are going to administer any medication or handling the patient. The most effective and important point we should keep in mind is hand hygiene. A single hand hygiene can break the chain of infection. Proper handover and takeover. Whenever you are taking handover from other staff, take properly and give properly. Proper labeling. There must be a proper label on the CVC line when it is inserted. Dressing done by, last dressing done on, at, timing should be there. Aseptic procedure. Use aseptic procedure, date and time, check for dress and ACL and alert, as I already told you. Prevention from cross infection, accurate documentation, and accurate communication. Why we need accurate communication? Because lack of communication affects the health of the patient. Like I am not communicating the signs of infection to the physician, then how he will know the patient is getting CLABSI or any other infection? So accurate communication is very important for prevention of CLABSI. Thank you so much.
Thank you, Sonia. It was a very nice presentation.
Thank you.
Cleared all the topics. The slides you made, I think, is very, you made it clear also. You discussed the things nicely. Ma'am, Ritu ma'am,
Yes.
can you add on any key points or any specific
Yeah.
things which Sonia might have left in her PPT? Or can you
Yeah.
elaborate any other point you want to?
Yes, thank you so much. Firstly, I really want to thank Dr. Neeta Rani Kansal for, giving me this opportunity. As a microbiologist, infection control containing topic is always close to my heart. And also, I have to congratulate you and team because, it's a wonderful presentation, explained well, nicely photographed. So that's a very good thing. And nurses are really making such good efforts towards NTP control. We feel proud. And also, my thanks to Director NITRT. Coming back to the topic. So, yes, it was fairly complete, but I just have opinion about 2-3 things. The organisms which are isolated in the central line bloodstream infections, they are mostly coagulase negative staphylococci, enterococci. You also have Tanda species and some others. Now, one thing which has been talked about is hand hygiene again and again, infection control. Why is it important? Because these organisms, which are isolated in blood culture, also form the part of skin flora. So that is the whole reason of that connection. So when you're getting it from blood culture, even if you get it from blood culture, and even if the patient is symptomatic, if the sample has not been collected properly, it is not easy to really say that, blood culture may whatever has grown, jo bhi aaya hai, is it coming because of skin contamination or is it bacterial pathogen? Because most of these organisms are opportunistic pathogens. A patient is already suffering, immunocompromised, a patient who is predisposed, hospitalized, that is a patient who is going to go for central line. So even if technically he may not be immunocompromised, but immunity state is lesser. So these organisms are opportunistic. They find the opportunity and attack. So that is one thing which I wanted to emphasize. Second point which I wanted to say is that we've talked about infection control measures, about hand hygiene, hand washing, and other things that, okay, catheter should not be staying for long. Now, one thing which most people leave out, and it is very important, the nursing department has a huge role in this, is to also capture the compliance. So we all train, but where is the compliance point? So there needs to be a checklist in the place to see how the compliance of this thing is being done or not being done. So a modus operandi, somebody should be having this every hospital, there needs to be a checklist to see. That checklist can be done depending on the availability of staff. भाई कई जगह पे we know कि staff resources होते हैं, complaint होते हैं, तो week में एक बार check करो, daily check करो, as per availability, different sites check by base of observation whether it's happening or not. Give a particular gradation, and based on that, that feedback should be given to the main nursing superintendent and to all the concerned people, so that there is a scope for improvement. Otherwise, we only talk about it. So these are the two things I wanted to just highlight. Everything else has already been told by the presenter, so I didn't want to repeat that.
Thank you, ma'am. Thank you. Our nursing superintendent also with us. I think she may just after this session may contact unit in charges, especially ICU in charge, to carry forward what you have said right now.
I can
Maybe.
clear just now only.
Achha, you can
I think,
clear.
yeah, I think Dr. Ritu has made a very good point, and thank you for being an expert for today. I think we should have a check. Ideally, we have a checklist, but I think the implementation part is a little bit like dicey. Sometimes we check, but I think we'll make sure now we have a ICM with us, Miss Veera. She will be able to do it. If she can't do daily, at least once a week. At least randomly she can do, because I have seen 2-3 cases. She showed me the photographs where we have seen the cases of CLABSI, and we really want to improve the patient outcome. So we will do whatever that she has already very good simple things, alert and so many things, that we can make our own checklist with your help, and then we can implement it. That we will.
We're there to help, ma'am. We're there to help anytime.
That we will do, Miss Veera. She will contact you and will finalize the checklist, and then we will see where we are lacking and why we have these infections in ICU.
Okay, I want to also make another point. So infection control is a part of NABH. I think many people know about it. So in private hospitals, NABH is kind of something which happens. And there is a lot of obviously administrative push about it. It's in a government setup, because many of the nurses here may be from government setup or private setup. It may not be possible. But what can be done is that at least जो उनके points हैं उससे सीख कर कि कैसे कर सकते हैं, whatever limit is possible, हम उसी चीज को अपने अपने सेटअप में थोड़ा जितना हमारा feasibility है थोड़ा शुरुआत से उसको implement कर सकते हैं. Because documentation is immense in NABH. That much documentation is not required, but important things. So that's another thing.
Sure, we will do it. Then how many cases are there with the CBC line in ICU? No? Maybe 4 or 5. At least surveillance of one case, even if it's done, we'll be able to catch some points. We will do it. We will do it.
Absolutely. We can start with one and later on we'll see.
Yeah.
Sure, ma'am.
Yeah.
Sure.
Thank you, Sonia, for such a simple and very explained, very well, like in the simple language she has explained, and it was nice to hear you here. Thank you. Thank you so much.
Thank you, Ritu ma'am, for the opportunity, giving us opportunity to collectively explore the complexities of the case and gain a deeper understanding on this topic. Thank you once again.
Thank you, ma'am.
Now we'll move on to open house discussion. Is anybody from the learners, from the attendees can ask questions now? Any questions regarding this topic?
In the chat box.
Or you can either write in the chat box too.
Nothing in the chat.
बस मैंने पसंद कोई नहीं मेरा हाथ लगा के मैंने गुस्सा उठा मेरा हाथ लगा
इसको पसंद है
जो अपना यार
Any questions you want to ask?
You can write in chat box.
You can write in chat box too. If anyone if you hesitate to ask it here, please write in the chat box. So your questions and perspectives is valuable to us, and we'll share with here. It's a right opportunity to ask anything regarding the topic. You might be facing such cases in your hospital anytime. You can ask if you have any doubt. Any questions? Sister Ranjana is there today?
There is a question in the chat box.
Yes. What is the concentration of heparin solution to be used and the technique of administration? Ma'am, can you elaborate?
For flushing of this one.
What is the
for what purpose? For flushing, no?
what is the concentration of heparin solution to be used and the technique of administration? I think you are asking about flushing.
Yes.
Okay, can you say, ma'am, what is the concentration used?
Yes, yes.
Dr. Ritu, ma'am, are you there?
This is related to clinical. Can
Achha.
you answer this? See, I can answer this. See, this is the concentration of heparin is we are not using heparin here as a medication purposes. This is only to flush. So it depends upon the physician seeing the condition of the clinical condition of the patient, whether patient has DVT or whether the PTR is normal and what is the bleeding time, clotting time. According to whatever they prescribe, we will use that. So we will use that amount of heparin, that amount of units with the saline for flushing.
Is that clear? Yeah, Miss Gayatri Anupam has also asked a question. Collecting blood culture sample from central venous line is standard procedure. Is it a standard procedure?
Yes, of course. Dr. Ritu can say.
No. It's see, the two things, when you are suspecting the infection, you may sometimes collect, ideally speaking, you should collect it both from central venous line and simultaneously also from another. There is a disturbance here. There is, you need to collect the sample both from central venous line and also from any of the peripheral vein, just to rule out any other thing. So that is the standard procedure. But before collection, obviously all the aseptic precautions have to be taken, which I just told, especially the betadine and all, so that we don't take any normal flora. What we want to know is the actual pathogen, not the normal flora present in the skin. Yeah.
Thank you, ma'am. Any other question?
Hi, Shima.
Hi.
Ranjana here.
Hello, sister.
Thanks for remembering me. Sonia has explained so well. I really don't have any doubt or query today.
Thank you. Many of us have joined from other states too. You must be in ICUs. Seen many cases like this. You can ask any questions. Share your thoughts so that participate in discussions.
One more thing I would like to say, if there is no question. Dr. Ritu asked about the compliance of the hand hygiene. We are doing it here. We are using that WHO checklist where there are opportunities to wash the hands and actually washing done. So we have a compliance rate where we have seen in last year also and this year also up to June that the doctors are the one who have the least compliance. Yes. So that may be an issue because maybe I don't know where is the issue. I think whenever we have this observation, the compliance rate for the hand hygiene is least in the doctors.
Any other questions? See, your inputs will not only enhance the learning experience, but also there will be a success of our presentation too.
So, madam, irrespective of wherever the compliance is, irrespective of the categories, irrespective of the person, the whole idea is it needs to be cut down and a training needs to be given.
Yes, ma'am.
जो भी कोई पेशेंट से इंटरैक्ट करता है, जितना कोई पेशेंट से इंटरैक्ट करता है, उसमें उसका हैंड हाइजीन ज्यादा चाहिए. अगर नर्सिंग करता है तो नर्सिंग का चाहिए, अगर डॉक्टर करता है तो उसका चाहिए.
Even doctor,
It is just simple.
Even nurses are not doing 100%. That is about 70 or 80%, but doctors 40 to 50%.
तो उनका फिर उनको obviously enforce करना पड़ेगा इस सब चीजें. See, irrespective, as I just said, कि हमारा concept ये है कि hand hygiene का होना चाहिए, उसको इंश्योर कराने के लिए compliance होना चाहिए. हमारा पर्पस फॉल्ट फाइंडिंग का नहीं है, ये कहाँ पे है. हमारा पर्पस इज अक्रॉस द बोर्ड, सबको बताना, सबको दिखाना, सबको इन जनरल बोलना, so that it becomes less of an administrative issue and more of an issue to actually address the problem.
I'm just discussing our ICU observation only.
Okay. So we should actually then inform this to the whosoever, यहाँ पे not just NITRD, in every hospital. जहां से भी दिक्कत आ रही है आप उनके कंसर्न सी व्हाट आई एम ट्राइंग टू से इट्स मेनी हॉस्पिटल पीपल वुड बी हियर. तो जहां पे भी दिक्कत आ रही है कंसर्न एडमिनिस्ट्रेटिव चैनल को जो भी इन्फेक्शन कंट्रोल नर्स हैं in form of data and presentation reported to them so that then they will be able to take the appropriate steps कि इसको अब कैसे सुधारना है. यहाँ पे गैप आ रहा है, इधर आ रहा है, आईसीयू में आ रहा है, मेडिकल में आ रहा है, सर्जिकल में आ रहा है, इस पर्टिकुलर कैटेगरी वाले लोगों में आ रहा है, so they will take the steps to improvise it. And it's a constant effort, not one time job. It's like daily thing.
We need to streamline it more. Whatever we are doing, we are reporting it to the in charge infection control. That is Dr. Manpreet Bhalla. She was doing till even now she is doing. So we send the file to her. I think after that something has to be done, like what action to be taken, that has to be planned. I think we can do that.
Yeah, yes, Dr. Anita, the report comes to me, but it is very low. The compliance hand hygiene rate is very low. And then I think for that, we need to do the trainings. First thing is training and to check for the compliance.
Yes, ma'am. Yes, ma'am. We will improve upon this. We all will improve upon this. That how to handle this in a better way.
Thank you, ma'am. Anyone else to ask questions? Anyone who is hesitating, please come up. Remember, there is no wrong questions here. Every perspective is valuable. There is one more question. It's little different. Out of the 500 ml solution, how many ml to be used if the catheter needs to be flushed on? Stat.
I think, Pramod, your question is, I think we should not be preparing this in bulk. We should be preparing whenever we need for the patient, according to the units advised by the physician. Yes.
2 ml. Acha. Gayatri has written 2 ml. Okay, now anything else? So no questions? Any more questions? So we can stop here. I think we'll stop here now. We have almost covered all the key points that we wanted to cover. Thank you, attendees, for attending the session. I hope you all had clear instructions on how to join the session. It's been on 19th, so I think there might be no issues. Have a great day ahead. See you next month, next Friday. Thank you, Dr. Ritu Singhal, for being an expert. Thank you, Director Ma'am, Dr. Manpreet Bharla, for joining us. Thank you once again. Before leaving the session, you all are requested to share your feedback by clicking on the link given in the chat box. Before leaving the session, I request all of you to please share your feedback by clicking on this link that is given in the chat box. We will close the session in 2 minutes so that you can put your input in chat box. Thank you once again.
So we'll keep the session running for another 2 minutes. Till then, please give your feedback. If you have already, then you can leave the session. Thank you.
अब ये कैसे बंद कैसे करें इसको?